Thank you for taking the time to tune in with us. Here on Unclamped, we recognize that every patient and caregiver carries a story, each one shaped by unique experiences, challenges, and triumphs. Before we dive in, we want to take a few minutes to introduce ourselves so you can get to know the voices behind the mic, the journeys that brought us together here, and the passion that fuels this space. Because this isn't just a podcast, it really is about community, and every story matters.
Welcome, everyone. It is Feeding Tube Awareness Week. So we're going to do a special episode for Feeding Tube Awareness Week, which is February 8th through the 14th this year, which is 2026. That was hard for me to say. So we want to put a spotlight on some of the subjects and topics that come up often with feeding tubes and honor everyone that has a feeding tube.
And we know that feeding tubes can be overwhelming, whether you're new to it, supporting a loved one, or living with it long term. Today is all about connection, clarity, and practical support.
I love this episode. I think it's really important for us to all share. We all have our own individual experiences with feeding tubes, and I just think it's a great opportunity to highlight awareness and how we can help and support others on their own journey.
So for everyone that is new to feeding tubes or questionably on potentially going to get it, we're going to do some basic level setting so everyone can follow along. And what is a feeding tube used for? It can be used for a variety of things. It can be used for nutrition. So your formulas, it can be used just for hydration if you need. A lot of people use it for just medications, and some people use it for just venting, so letting stuff out. It's a tube stuck in your GI system just to help pass our esophagus. That's all it really is if you think about it.
And there are different types of feeding tubes. We have, NG, NJ, ND. G-tubes or danglers. Some people call them the peg. We have the buttons, GJ, just J-tubes. And also some people refer to their central line as a feeding tube.
Yeah, I think it's important to highlight that every tube has a purpose. So oftentimes when you're faced with that, come to Jesus moment of, things aren't working, I'm not getting enough in orally, what do I do? The first step usually is some sort of NG, NJ, or ND tube because it's minimally invasive, so it's not really a commitment, so to speak. But there's, as we just mentioned, tons of different types of tubes. And in my own experience with my daughter, we went through all of them. So I think it's really important to just highlight that while there are a bunch of different types of tubes, that it's also important, especially if you're new to your enteral journey, of learning what those tubes are and what those choices are and how they fit your circumstance. So that way you can ask the right questions and figure it out with your medical team together. Just because, the typical path is to start with an NG or an NJ, I don't know. For me, it doesn't necessarily mean that that's where it has to start. I think everybody has to start their own journey in their own way, and familiarizing yourself with all the options is always just something that I encourage, even with parenteral nutrition too. Like it's very similar and very much the same. Go ahead.
Yeah, and the reality is it really depends on if you're a pediatric, a NICU baby, or if you're an older, if you need it for a short period of time. So it depends on why you're going on a feeding tube. A lot of people have esophageal cancer, and they might only need it while they're getting the treatment. But then they're good, or if you have dysphagia or any type of trauma to the neck, you'll have normally something that's going through your nose and going into your stomach or your intestines. But then it's, longer term, you normally transition to something that requires a stoma.
Yeah, no, that makes sense. I feel like we all have our own personal experiences with feeding tubes, and that like coming home with a new device. Gabby, how was that?
Yeah, it was coming home with a feeding tube was, so I think the big thing is there's not really training. Like, so you don't
Yes.
really get trained. I hear from a lot of people in our community that like they just get sent home with it and it's kind of like you figure it out. And I mean, we did have some training, like we're at a really big hospital, but I learned things along the way, like trial and error, learn from friends. Yeah, I feel like that's what happens when you have a feeding tube. You kind of just figure it out on your own, and it's tough. It's hard.
Yeah, I feel like enteral feeding in regards to training is just so overlooked. I mean,
Yeah,
it seems simple enough to someone who, lives the life and is clinical, but for people like us and for parents that are just sent home with a feeding tube and a child that seems so delicate and fragile, it's like how are you supposed to navigate? Like what do you do? And I think that is often very overlooked, is that training
yeah,
piece. And the products that you use. I mean, it's like there's just not enough kind of like how-to guides with enteral feeding.
yeah, yep.
You could have had a legacy feeding tube, and then you all of a sudden go into the hospital and they switch it out on you, and you didn't know necessarily. And you get home and you realize you don't have any connections, so you can't use the infant because how are you going to connect? You don't have any connections. So it's definitely, it doesn't matter the age. There's definitely a learning gap, I would say. But that's what we have our community for, is because we learn the most tips and how to really live life from from our friends, from the community that we live in.
Yeah, I don't think I like my son's G tube used to leak a lot, and like I didn't find products that worked until like I asked my friends, and they're like, "Oh, we use Mepilex or we use Tubi pads," or then I was like, "Oh, I could use both," and like it just works for
Mhm.
us. I feel like we just learn from each other, and of course, like you know, run it by your doctors, and you kind of teach them too, and like at least I have a team that is really open, and so they'll be like, "Wow, thanks for sharing. Now we can help other families." But yeah, that's
Yeah,
when like social media and like friendships you learn together.
yeah, no, definitely. So Olivia received her first feeding tube at 13 months. So that was in 2007. And I attended my first OLI conference in 2009, and my mind was completely blown.
Mm.
The exhibit hall, I mean, a feral bag. No one told me about feral bags, and that was just huge, especially for Olivia, because she was having a hard time tolerating the J feeds because she had gastroparesis, and the ability to vent her stomach while trying to do feeds was just a total game changer. But that was not explained to us. And when I tried to, explain what we were experiencing at home, we were met with, hmm, I've never really heard of that before. Okay. And then all of a sudden, I was opened up to a whole community of people who were like, oh, yeah, well, I use this or I do this. And it was just like, it was just, it was amazing to just see a community of people that were also able to understand and have like those aha moments together with. So it was really important.
And one thing that I don't know that a lot of people know is there's approximately 500,000 people, um, or more at any given time on enteral nutrition, right? That are using enteral nutrition or have the feeding tube. And so the community isn't as small as we would like, as we always think it is. And that's just within the US. And then, thinking globally, it's
Mm-hmm.
in the millions. But it's a fairly large industry. And when you start looking at the formulas and stuff like that, you really realize how many people are on enteral nutrition. And what does it mean? Enteral nutrition, right? It's just food that's bypassing our esophagus, our mouth and our esophagus, going directly into our stomach or our intestines. It's just food. Like for some people, it's literally what you made your spouse made you for dinner, and they put it in a blender, add some extra water or maybe some formula with it, and then it goes through, skips their esophagus and goes directly into their stomach. So now that's not for everyone, granted, but there are some people out there, and a vast majority of people out there like this, that they don't need the specialized formulas. And then we take this and we over medicalize. We use so much medical stuff to just say, oh, we're skipping the esophagus, we're skipping the mouth and the esophagus, and we're going into the stomach or into the intestine. To me, that's just mind-blowing how we try to make things more complicated when we can make it simpler for everyone to understand and truly use and not be as afraid of. If you think about it that way, it's like, it's just food going, the skipping part of the system.
I think that's one of the differences between pediatric and adult care. So for me, for instance, Olivia got her G-tube at 13 months. So obviously there wasn't much conversation with her or readiness, but she didn't receive her J-tube until age 4. So we were talking about a whole different stoma because we separated them. And I found a lot of comfort in a children's book called When Jeremy Jones' Stomach Stopped Working. Coincidentally for me, it was centered around mitochondrial disease. And the young character in the story had mitochondrial disease and suddenly had the onset of gastroparesis. But it really went through that whole story of what to expect when you get a feeding tube, and the benefits of having one, and kind of feeling like you could incorporate it into your daily life. And I remember having those types of supports and having that just real simple language, and warming pictures really helped us, go to that next level of getting another tube and having a J tube. So, I mean, I empathize because I feel what you're feeling, Crystal, in the pediatric space, but I can only imagine, like, without all of the picture books and the nice, like, extra thoughts that go into it, what it would feel like for an adult patient at the start.
Yeah, well, I think that's like part of it too, right? The emotional side of getting a feeding tube. Like you go through all these, like, I would say phases of like hard or like happy to get it or sad, or maybe like you feel like your body's different. I think that's a big part of it. Did you guys ever feel that, like when you got a feeding tube or for your daughter?
Yeah, I mean, and all of those emotions are real. Like, I have to say that anytime you incorporate something that's completely different, that you have no choice but to get used to, there's a process. Like, and there's a process of grieving and being able to be like, okay, establishing the new normal. And it's like, okay, I'm going to establish a new normal, I mean, like COVID, like, God, when they were like, establish a new normal, I was like, will you stop saying that? Because that has been my life.
Then something happens.
Right? Like, that has been my life, like, since 2007. Thank you, public, for catching up. Sorry, but it's true. So, but allowing yourself that process and really being able to accept the fact that this sucks. Like, right? Like, it sucks. Like, it sucks that, like, for me as a mom, that I can't just like go to the grocery store and buy what I need to buy and feed my child, sit down and have a normal dinner, quote unquote normal dinner, and let my child eat and watch them, gain and grow without all the extra work. And I mean, I think oftentimes our medical providers, not intentionally, of course, they just go rote and they just like, this is what we have to do, and they develop a process, and that process has a high efficacy rate, and then they just want to implement it. but the whole family dynamic and managing each family and what they're going through is really what takes it to patient-centered care. And I think that that's often overlooked. And then us as patients and families, we're just kind of like, we feel deficient because we're not able to just take it and run, and just go with it. So I think that definitely, giving yourself permission to feel however you want to feel about it and fall out is 100% normal.
For me, one of the things that I find difficult is when they use the word failure, right? You have to fail something. Well, that makes it, as a patient, it means that I failed, right? That's how it sounds. That's how it feels. So instead of saying I failed in G tube, I failed in NJ tube, no, that I didn't fail anything. The tool, the system failed me. The NJ tube or NG tube, because I've had both, failed me. I couldn't use them. And so just changing the way we frame it as a patient makes it easier to accept that you need this tool, and it's easier to cope with instead of feeling like you're a failure when in all reality you're not failing. Your body might be failing something, but you as a person, which is what we should be looking out for, isn't failing anything. The system is failing you, or the tools around you are failing you.
Yeah.
I mean, I think it's safe to say that we've all had our moment. We've all fallen out about, feeding or not being successful or not feeling successful, whether that's true or not. I mean, do you have like a personal moment where it just kind of like clicked for you, where you're like, you know what? This is what it is and it's okay?
For me, it would laying in the hospital bed and knowing, well, when I was going through in NJ and it was hurting and it was causing me to go to stomach, and it was horrible. And I'm like, guys, we have to pull this. This is not working. And I'm like, it's okay that it's not working. We have other means. So we'll just move on, can we? And it worked. So, and now I'm obviously doing pretty well. So I would say that's a win.
That quality of life component, I think, is often overlooked. It's just you become so tunneled and so focused on the goal. We have to hit this rate. We have to be able to get in this many calories, and it looks good on paper, right? I mean, you can build like your dietary guidelines, and they're going to do all the things. But like, what about the person that has to adhere to that? And then you get into compliance, and it's like, well, is a patient really non-compliant, or is the program that you're building just not working?
Yeah, I think that's like where, at least myself as a caregiver, but I'm sure patients do it, is where you just kind of like advocate for yourself. Like, this isn't working for me. It's affecting my quality of life. Like, I'm not going to do it. Help me figure out a different way.
And I often say, help me, help you, help me.
Yeah.
Because
Right.
I'm like, allow me to help you so that you can help me. And it feels like that at times. It's like, I just need you to do this or that, or this is what I need to come out of it. And then you guys can build out the, macronutrients or whatever, or micronutrients that I might need, or the hydration. But I truly just need to be able to enjoy my life and live. And I don't mean just survive. I just want to live. And I think that's what most of us want to do. Which is why I think like building routines and stuff. Go ahead. Yeah, sorry.
I think like sometimes teams also like don't know it. Like they don't know. They think like, oh, you're on a good plan. You're doing good. And it's not till you're like, I hate this. I like at least for my son, overnight feeds like were rough all around, like for his health, but like quality of life and our quality of life. And we just got to the point where we're like, we are not doing this, but we are doing it this way. And he's still getting the same amount of calories. Help me figure out how we can continue on this new path. And like they had no idea it was such a big impact on our life until I told them. Sometimes just like talking about it.
Mm-hmm. No,
And
oh, go ahead.
and talking about it with somebody else so that when you go into the office, so it's one thing for you as a parent and your child, but when you're an adult and you're going in alone, don't go in alone. Take a buddy in with you. If you don't have a partner or spouse or whatever, take a buddy in with you, and so you would have already talked through everything, and they can bear witness to the struggles that you're having, because sometimes in those moments we can't articulate appropriately
Mm-hmm.
what we're trying to say, because we're frustrated or tired, or we're just too weak because the system isn't working for us. Our regimen's not working, and we have tried other things, but we're a little nervous to tell them. I know some people, like, they'll be on continual enteral feeds, but it's not working for them because they're literally supposed to be hooked up 24/7, and nobody wants to be hooked up 24/7 to do something, especially for enteral feeds. And so they'll try like small boluses, or obviously they'll disconnect to go take a shower or something like that, and that's okay. I'm like, just tell your team what you're doing and make it so that they could figure out, hey, maybe we can decrease your time or increase your calories per, when you're discussing the different types of formulas, right? There's all different types of formulas out there that makes it easier for them to change your calories without necessarily changing your volume.
I think that's a great tip in general. Like, bring someone with you. Like, I know when
Mm-hmm.
I really need to like tell the team something and it's like heavy, like I'll bring in, like, I'll have someone come with me, like usually like Tony, and I'm like, hey, like I might not bring this up, but remind me. Just say, hey, remember you wanted to tell them this? And then that'll be my cue, like, all right, I'm gonna tell them this thing, whatever it is.
I think that's
Yeah.
a good tip for no matter if we're talking
Yeah,
enteral
for
feedings or if you're going to your
Yeah.
cardiologist or whatever, your PCP,
Yep.
or seeing your lawyer or whatever. Just bring somebody with you. Bring
Yeah,
somebody with
patient,
you,
caregiver,
or
anyone.
whatever.
Yeah.
It's a good tip.
Yeah, no,
Good.
I do that too. Like, my husband, he's working a lot of the times, but I'll be like, listen, you have to be on FaceTime. You have to be ready to go. Like, the ad appointment starts at 1:15, and you need to be on because sometimes you feel like the things that you're going to share or the things that you're going to report are like very unique and different, and you're worried about how you're going to be perceived. So you need someone else to like be able to like be like, yeah, that's fact. Like, that's happening. Like, that baby is waking up every time between 3 and 5 and just vomiting a whole lot of formula all over the floor. So what are we going to do about it? And I just think it's important that, you're stronger in numbers and you're stronger with your support system. And unfortunately, sometimes, it requires being validated by someone else or getting those reminders on um, when to bring things up, and, just kind of push a little harder for a better answer, a better explanation for why it's not working and getting a better situation. But so I think that I feel like we should just dive into like daily living. I mean, like, because so you're home, you have a feeding tube, you've established that this is like, what's going to get you to the next level of, your goal, and you're in it. And like, what do you do? Like, how do you learn from that experience? How do you incorporate it into everyday life?
Those are some good questions. I think for some people, it's really like, you love kits. Jamie loves kits. We all know that by now. But
Yes.
I think really having things put together in whatever manner is going to work for you, and truly just make it part of your daily routine. Routines, it doesn't matter if we're talking enteral nutrition, parenteral nutrition, or standard oral nutrition, right? Or sleep training your baby or your puppy. Like, once you get into a routine, your life is so much easier. And I'm not saying like a strict regiment of a routine, but a general common sense routine that works for your life. Like you're just switching out your routine a little bit, switching it up a little bit is how I see it, from when you used to make your breakfast, lunch, or dinner to you're still making your breakfast, lunch, or dinner. It just happens to look a little bit differently now.
I think for me, I like to be prepared just for like everything. So like having everything that I need in case of emergency helped me a lot. Like just I carry this little kit of like a backup G tube and then the syringe and an extension and a gauze and like just so if I'm out and about and something happens, I'm prepared.
Gabby,
Yeah.
you said backup G tube. So do you change your son's G tube at home, or does he go in?
Yeah, no, we change ours at home. Actually, yeah, we've always changed it at home. Like after he got his button, then, I think we were trained. We might have been. I don't know. I know how to change it.
I feel like it's one of those things that you watch in The Office 1 or 2 times and you're like, all right, I got this.
Yeah.
Like we can do it. And you just
Like,
take the reins and go.
I had someone yesterday, like in class, the other day in class, a nurse we were being trained on G-tubes because, I'm in nursing school. And she was like, yeah, if like a G-tube pops out, she's a school nurse. She's like, we call 911. And I was like, what? I'd be so mad if my son's school called 911.
Don't send me the bill because that's something you don't need to call for.
No,
Sorry.
but that's a practical tip, right? So if your G-tube pops out, what do you do, right? So people freak out about this, and it's really depends on where your stoma is, right? So if you have a well-formed stoma, it's going to take a long time to close, but you'll still want to put something back in there. You could actually wash off that G-tube and stick it back in if you have no other option. You could also, I think sometimes they send people home with urinary catheters to use. Straws are a common thing that I have seen. And depending on the size of stoma, you want to use a different straw. Either the coffee straw is going to be way too small. Do not grab a coffee straw. You basically ruined your stoma there. But anywhere between like a normal straw to like the bigger McDonald's straws, those are good.
I think
good size straws too.
Like most doctors have like a on call. So like when in doubt, you can call them and like that's it. Like you don't have to like panic.
No.
And what I found, because I had a child relatively soon after. Like David and Olivia are only 3 years apart. So what I found is, I don't know, most pacifiers now when you buy them, they come with like a little plastic container. So that little plastic container, we particularly use it, the Advent ones, is perfect to put a little G-tube, a little, lubrication like packet, and the slip tip syringe, the 5 ml slip tip syringe. It all fits perfectly in there. So I would just put that right in my diaper bag because I had a plethora of those little things because my kids loved pacifiers. And that was just the perfect little compartment I always had a G-tube on me, in case of an emergency or in case, it got pulled out because she was playing or whatever she was doing. Because I think that it's also important when you incorporate tube feeding into daily life is that you remember that the whole objective is quality of life. Like going to the beach, go to the beach, please. You can get that dirty. I mean, I used to bury Olivia. Yes, I used to bury Olivia in sand. The sand was all in there. I mean, might not be great for like granulation tissue. I get that, but like, it's okay. It can get sandy. The kids eat sand.
I ate a lot of things as a kid. Sand was probably one of the more benign things that I ate. But you were talking about how you both had G-tubes, right? That you have at home, you change it out. It's very interesting. In the adult world, they don't like it when you ask initially to change out your own G-tube at home. A button. They're like, no, that's not possible. And so it takes a lot of self-advocacy when on the flip side, if it's a pediatric patient, they expect the parent to be changing it out. But if it's an adult patient, they're like, no, you have to come into the hospital to get that changed out. And it's like, no, you really don't have to. If you're able, if you have mobility, you can change it out yourself. If not, somebody in your family, or if you have someone to change it out for you, they can easily change it out. It's really interesting to see the two different sides of pediatric versus adult and what they expect an overwhelmed parent to do to a child that they're exhausted over versus an adult that's in their 40s and they're like, oh, who's has full ambulation and everything, and just a little problem. So like, they have something wrong with their esophagus or something, and they can't, but yet they're still working full time with their hands and all that. But their doctors are telling them, nope, you have to come into the hospital every 3 to 6 months to get your tube changed. And it's like, no, guys, self-advocacy. You can get this done. You can do this. Prove it to them. So
Well, and I think that's like oh, go ahead, Gabby. Sorry.
No, I was just gonna say, like, I think too, like, I can change it at home and everything, and now we kind of incorporate it into our clinic visits. We're just because it works. Like, he knows.
Yeah.
Because it works. Like, we go into clinic and it's like a thing. He gets a new G tube. We have labs, or he has labs. Like, we have a routine. So, I mean, yeah, I like getting it changed in the hospital now, but before I didn't.
Yeah, I think routine is so important, but I think also like gauging the comfort of the patient family, like, because some families don't want whether you're an adult or like a caregiver, they don't want to be in charge of that stuff. It's just it's another responsibility. It's just it can feel like a burden or just another thing. So I think it's important, like, to give choice, right? Like, I mean, like, even when I'm parenting my kids, like, it's like choice. It's like, we can do this or we can do this. Like, you just, like, it's not like this or nothing. And I think that's also a really great way to approach things. And I feel like patients would be really receptive. I know I am when, I'm given, like, there's two ways we could do this. What's your comfort? Like, how are you feeling about this? Like, how can we make this experience good for you and for your children? Then, like, you have me. I'm like, okay, we're going to do this. We're now partnering. This is all good. I mean, that's where I feel like sometimes the mark is missed. Just in general. But how do you guys
a guided
feel?
choice?
Yes, yeah, like a guided, like, so relational care instead of transactional care.
Yeah.
Like build a relationship with me, figure out what help me figure out what I need, because I mean, I don't know, but if we make this relational and not just you like a transactional like visit, I'm going to feel more apt to listen and to be, engaged in the care.
Yeah.
So I think that's important. But one of the things that comes up all the time, and I had this once with Olivia, was clogs. Like, and that's scary. Like, because especially if you are on a pretty heavy like dependence on enteral feeds and your tube gets clogged, like, what do you do?
I use the little blue thing that comes in our G-tube kits. Yeah, yep. I've used that, and that's helped unclog. I think the big thing too is like learning how not to clog it.
Right?
Yeah. Definitely learning how not to clog. It's a good thing. But then it depends on what it's clogged with, right? So I've unclogged people's with just hot water and going back and forth, which people forget about. The simplest thing, hook up hot water, not hot water, but you know what I mean, warm water, and go back and forth. Use vinegar. I've used, which everyone hears the classic Coke one. Yeah. So vinegar is basically the same thing, right? Using an acid.
I was told baking soda.
So that's the opposite, right? So making the baking soda, if it's too acidic, using the baking soda. You can also, you'd be careful with this one, but if you use baking soda and vinegar or Coke, try one and it's not working, try the other one and it will slowly fizz. And use very, like, dilute the vinegar, because it's definitely going to cause some issues if you don't want it to buzz up that much, or you're going to have an exploding G-tube, which in the old world would have popped things out, but with the infants make things a little bit more challenging, wouldn't you say, Jamie?
Yeah, no, definitely. It took me a hot minute to get used to it. I don't know if I'm still in the transition phase. We held on to legacy as long as we could. I mean, I get the reason why, and the reason why is it makes total sense. Because of the errors that were happening with with IV versus enteral. So I'm not disputing that, but it has been its own journey, that transition from legacy to ENFit. I mean, like, even with especially with medications, because Olivia relies heavy on her enteral for medications. She doesn't do feeds anymore. They're not for her, and she's an adult and she can decide that. But we do all meds enteral. And those I don't know, what do you call them? Loraloc? No. Yeah.
Well,
the Loraloc versus a slip tip. Well, no, it was a Loraloc. Now it's
the Loralocs are the actual ones for an IV, so it is still a Loraloc type of connection,
but it's ENFit.
But it's for an ENFit.
Okay. Yeah. So that's been a really hard adjustment, and it's been a financial burden, because the transition happened during COVID. Like the heavy lift of the transition happened during COVID, and supply companies just didn't have the syringes to accommodate that transition. I mean, now they do, and that's fine, but I'm just saying, I'm dating myself, but it was hard.
ENFit is not good, like people who drain or have to vent. Like, ENFit's so much smaller, so it makes it hard.
I brought that up in multiple exhibit shows with our ENFit providers, and they swear that the diameter, right, is the same. And I'm like,
I know, but like, we know things are the same, and then it's not the same.
The diameter of the actual tubing is the same, but, well, I guess it depends on which French you're using in general. But then the actual connection is smaller.
Yeah, it's not.
Yeah.
So it's not the same. And with that 90-degree turn coming out, they do not drain the same way.
And if the patient says it's not the same, it's not the same.
I mean, you need to hold a focus group. Like, it's not the same.
Yeah. I mean, even just to get gas out, to get air out, it's, versus if you really want to get out any liquids, it's a lot harder. Sometimes you actually have to use the syringe to get it started before you can hold it over the sink or wherever you're draining into. If you're draining into a Faro bag or whatever, you might have to actually use a syringe to start to get it going. But a lot of people just use a sink. It depends on the situation, but yeah, you can easily just drain it right into your sink, or while you're showering, drain it. Especially when you've eaten too much orally, because yes, you can still eat if you have esophagus and you can swallow, and that's not your main problem. You can still eat while you have a feeding tube, a G or a J or a GJ. But yeah, I find venting, and people don't talk about venting. Talking about lack of education. That's one thing that and like all the support groups and stuff like that. When people find out that they can vent, and then they vent for the first time, and then they come back and their face is like, oh, I didn't have to deal with that, or I didn't have to vomit it back up, or I didn't have to deal with that aching, horrible stomach ache. It's quite interesting to see how relieved they are on their faces when they discover venting.
Yeah, I mean, I think that venting should definitely be discussed. We found out, through other patient families and just, tips and tricks that people have shared along the way. But I do understand why I understand why it's not necessarily openly shared, but this is where like just being able to educate people helps because venting causes losses and then you're dealing with the hydration and the electrolyte components. So obviously it's not ideal to have to vent. But again, there's that quality of life component where it's like, well,
Mm-hmm.
yes, it's not ideal. Understand why it's not ideal, but you have to meet a patient where they're at.
Yeah.
And like by like hiding this very high quality of life tip or option is actually, you know,
It can be
counterproductive.
harmful.
Yeah,
Yeah.
I mean,
Yeah.
it can be. And I mean, Olivia has such a greater quality of life because she will take more risks and she will eat more, which is actually a positive because she basically constantly challenges herself every day knowing that she has a fail-safe. And that fail-safe isn't vomiting or spending hours by the toilet. It's, I can get this out. And she's mindful about what she eats and how she eats it. But without venting, she would probably live in that very conservative, safe space
Yeah.
and probably wouldn't have made the advancements that she has over her years. I mean, she was completely NPO, and now, she can sit and she can eat about 40% of her calories. I mean,
Yeah.
that to me is
And you
huge, but
know
like,
what to do. She knows what to
yeah,
do if like she vents too much and needs extra hydration or like how to replenish. Like she
yeah,
does
and
it
it's all about
safely.
education. It's all about
Yep.
education, meeting a patient where they're at, being like, okay, like, this isn't necessarily something that we encourage or we want people to do, but we also understand like this is where you are and this is what you might need to be able to feel like you're living a higher quality of life. I mean, it's
Yeah.
like I feel like that discovery doesn't happen enough. Like
Yeah.
why does a patient want to vent? Or why, like, what is the goal? Like, I think establishing goals with your team is the most important thing. Like, they're going to have a lot of demands, right? Like, you're going to come out with a whole care plan and it's going to tell you all these regimented things, but like you equally get to say, I have goals too. Like, if I'm going to incorporate this and I'm going to take on this burden of doing all of this, I expect to get this out of it. And I need this to happen for me for it
Yep.
to be, for it to make sense. I just,
And it's okay if your goals change. Like I think
yes.
too, people are like, at least my experience, like we have a goal and then it doesn't work out, and I'm like, ugh. But it's okay. Like that's life. We have a new goal, and then we can work together.
Goals
Yeah.
change all the time in everyone's life. So
Yep.
why would they not change? And what you need changes, especially if you're talking,
Mm-hmm.
it doesn't matter if you're talking pediatrics or adults, right? So just as we naturally age from infants to elderly, our nutritional goals change, our life
Yep.
goals in general change. So they need to change in parallel so that we can meet them. And it doesn't matter how we're getting the nutrition in. They should meet, those goals should meet our goals of life, which could mean that we're doing multiple therapies at once, right? Because if your goal is to be able to work and travel and whatever, that could take a lot of hydration. And we're talking about venting,
Mm-hmm.
which potentially loses electrolytes. So maybe, well, one, maybe you'll be doing electrolytes through your G or J tube, your feeding tube. But maybe you'll also be doing some normal saline through a IV,
Mm-hmm.
through some sort of central line or some IV therapies of some sort. So having like dual therapy also isn't a bad thing. It's just what you need to live your life.
Yeah.
And it's really like your son is on dual therapy. And
Yep.
so, but I find it really cool because your son does a lot of it. He's on dual therapy, and if my understanding is right, the way he gets his enteral is also dual ways of getting enteral.
Yeah, it's like 3 different ways or 4 different ways. And it
Four
just
different.
depends. Like on weekends, we'll use the pump a little more, just like quick boluses during school. And we like at home like the non-NFIT, but for school, we send the NFIT because it's like you kind of less risk of him getting it everywhere. But yeah, we do pump, we do the elastomeric, we do syringe. He can eat, he drinks.
Mhm.
We do like Pedialyte when he needs extra hydration, if he doesn't need like IV hydration. And like, it just depends how he feels. He'll be like, can I drink it? Yeah, drink it. Or if he, just doesn't feel like he can drink it, then we'll put it through his tube.
Yeah. And a fun, interesting thing is, so for those who are completely NPO, let's say they have an esophageal problem or they have ALS, so anything involving dysphagia or they can't swallow, right? So it's gonna sound a bit gross to some, but if you take your favorite food or flavors of those foods and put into your tube, especially if it's a G tube. J tube doesn't work as well. The G tube, and you belch, you can enjoy the flavor of whatever that food is. I know a lot of people, I
Cool.
know it sounds kind of gross, but um, there are a lot of people in my world of neuromuscular and motor neuron that that's the reason their esophagus doesn't work. They can't swallow anymore. The muscles are really weak, but they have a G tube, and but they can still, like, their stomach still works perfectly fine, so they don't have this motility. Not really too bad anyway. They can still break down stuff, so they can do the blenderized foods and mix their formula in with it, and they can take some barbecue sauce if it's not even ribs. They'll take the barbecue sauce and put a smidgen of their favorite barbecue sauce in, and then they'll do their feeds, because then in their head when they belch, it will taste like the barbecue sauce. So they're having their
That's cool.
ribs. So it's a fun. It's not.
Yeah.
It's a interesting trick to get your brain to think that you've eaten something that you really crave and miss, without having to put yourself at risk of eating it, because we know we're still going to have gas, which is why we're venting. But yeah, so it really does depend on your goals of life.
Yeah, and I think establishing those goals up front with your provider and like always readdressing them at your clinical visits is really important. Because like I know for us with example, like we went through everything. We went from an NG to a straight J. So we did all the tubes with Olivia. And each progression was, well, we have to do this. Like it was almost, we almost were taught that, or we were taught that advancing to parenteral nutrition meant that we failed. And, I look back and I mean, she's a limited access patient now, and we did it because we wanted to do our due diligence. We wanted to do everything and anything we could because we didn't want to fail our child and we didn't want to expose her to greater risk. But if someone had mentioned like dual therapy, like, hey, we can do a little bit of both, and taken that pressure off of her little body and off our minds and conscience as parents. I mean, sometimes I wonder, would she be, I mean, her path was her path, and that's fine. I'm totally like, I've had my come to Jesus, it's fine. But I mean, but maybe she wouldn't be a limited access patient, if there was more conversation. And I believe that everyone that cared for Olivia had her best intentions, and that's not what I'm saying. What I'm saying is that I wish that there was more conversation. I wish that there was more, what's your goal? Because my goal was that she could, play t-ball. My goal was that she could go to school all day and not come home tired and end up in the ER on Friday night, because she had exhausted herself. Like, so those are the things, like, I just wish that there was more whole patient care of like, what are we really trying to establish for this patient? Because sometimes we get so tunneled on calories and ins and outs, and you literally just become a medical record number. I mean, you just become a chart, and I just think that there's just so many nuances, especially with enteral feeding. There's so many ways that you can do it that I hope for our community that discovery definitely becomes more relevant and more introduced, and that I feel like it's going to come from us, from the patients of
Yeah.
offering that, hey, I have some goals too, you know, and this is what I need if I'm going to commit to this level of a therapy, and that be accepted and normalized.
And I know a guy who actually has 3 squares a day, if you wanted to say it that way. He completely bolus feeds, so he literally pours it into a cup and holds it up. Actually, he uses the arm to hold it for him, and he sits there, and while everyone else is eating, he's eating right along with them. And it's no big deal. It takes the same amount of, like, pours his formula in, hooks it up, boop, there you go. You
Oh,
had my
free arm.
breakfast.
That's what it's called, right?
Yes,
Free
yes,
arm.
the free
Mhm.
arm, the free arm. Yeah. So because you have a free arm now, you have both your arms free, and it's standing there. The free arm. I used to call it the octopus arm because that's what it looked like to me. But yeah, like that works. It works great for him. And then, like, your son uses a syringe and a pump. And then I know people that are, like I said, connected 24 or connected to a pump, either however long it is. And that's the only way they feed is through a pump. But they take their medication through through a syringe. So really setting your goals, but then knowing when it's time to reevaluate your situation, right? So as we're changing our goals, we need to reevaluate. And you were talking about the 3 different modalities, meaning normal oral eating, enteral, and parenteral, that your son does, Gabby.
Yeah. And like we
And
do meds differently. Like if he does his own meds, like he uses a slip tip straight into his button, which isn't always recommended, but it works for him.
Mhm.
And like we haven't had issues. Or we'll use the extension. Like it just you can kind of do whatever works for you in that time. And I think that was life changing when we realized that. Like, okay, we don't have to do it just one way. Like we could do it all the ways.
Mhm.
yeah, and with his diagnosis of, we'll say the short one, SBS, Fantasy gastroschisis, but which led to short bowel syndrome.
Yep.
A lot of patients with short bowel syndrome, throughout their course, there's now medications that they can take to help them absorb, depending on how much of their bowel
Yep.
that they have left, right? So with those medications, we're having to constantly have the conversations. They're having the conversations. I've even had the conversations when I don't have SBS. It's like, well, should I be on a GLP-2, not GLP-1, but GLP-2, to help the absorption, right? So if we can help the absorption, could I then eat more food orally and get more food that way? Which is often the question with SBS patients, who I've known several who's been able to transition from having TPN, EN, sometimes dual therapy, and then, now having to, they eat 100% orally. Some of it is
Yep.
more liquids, and they definitely have to be extra careful with hydration, with the absorption and stuff like that. But so there's so many transitions and reevaluations that need to occur. So how do you guys, what do you guys, when you guys have had reevaluations, what's been going on with that?
Yeah, I think mostly it's like how he's doing. We've gone through like phases where we're not on any enteral and it's full TPN because maybe he's post-op or maybe his gut just isn't working how it should be, or how it should be, whatever. And yeah, like we've been on no enteral, then we go on enteral, and then suddenly he does really good, and then we're actually able to wean a little bit of calories or hydration, and kind of just playing that dance. But before I used to get so like fixated on like, oh my God, he had to go up in calories or hydration, or even fixated on like, oh, he's going down. And it's like, now I'm just like, it's whatever his body needs.
Mm-hmm.
I'm happy with that. Like, as long as he's doing well, that's it.
That's a
Mhm.
process for caregivers. I mean, I can speak to that
Yeah.
with both of my kids. Like, you want to control so bad because you want to fix it, you want to make it better, you want to make them optimal. So, like, the doctor will give you a number or they'll give you like the care plan, and you're like, I have to follow this to a T. Like, if I don't follow this to a T, they're not going to get better, or they have no chance of getting better. Or
Yeah.
you know, you watch them take risks, which they should, and you like, well, for me, like, I would get like really anxious. Like, you know, you can't eat that and be fed like through your G tube because you're just gonna vomit and we're gonna lose everything. You know, those are moments where like it's hard to step back and be like, you know what?
Yeah.
They have to learn how to regulate, and I have to watch this. I have, even though it's a scary movie, I've got to watch it till the end and just see how this is going to work and what's going to work for them, and allow them and their care plan to possibly fail. Because I
Yeah.
think that that's the scariest part, is like allowing it to fail, whether it be your child being behavioral and just eating more than they should or not eating enough, or you know, the care plan itself failing. I feel like it's just such a balance, and there's a lot of psychosocial and emotional components of that from a caregiver's perspective that wasn't addressed. Like, I was just supposed to be able to do it. I mean, it's a care plan. It's on your discharge summary. You just should be able to do this. And why is this hard for you, Mrs. Scally? And it's like, well, I don't know, because I'm watching my child vomit after eating daddy's pasta because she loves it so much. And I'm worried that, you know, she's going to dehydrate overnight. I'm sorry. I'm not in it. Like, you know, I just think that that's a piece of the equation that's just often overlooked. And then, you know, we become misunderstood as parents and caregivers. But then once we have that aha moment where we're like, "Psh, they got it. Just gonna let them fly. Fly, little bird." And if you fall, I'll come get you. But it takes a while to get there.
But
And I think that needs to be talked about.
I like how you just changed the wording. If you fall, I'll come and get you, instead of if you fail, I'll come and get you. Because we're not really failing, we're just falling, and we're just like anything. We make mistakes in life, and that's how we learn. So
Yeah.
unless you allow us to make those mistakes, and we're not talking catastrophic mistakes that are going to put us in the hospital. We're talking, you know, mistakes that are going to make us really uncomfortable, vomit, you know, not feel so great. But if we didn't have tubes, we would still be making those mistakes. How many
Like eating
kids
Taco
or
Bell.
exactly. Like, how many kids, how many adults eat too much food and then have a really bad stomach ache?
Mm-hmm.
Or is running to the bathroom because there's nothing wrong with their GI system, but running to the bathroom because, they shouldn't have eaten so much ice cream or greasy, whatever, Taco Bell or whatever your choice is. Mine would not be Taco Bell because I don't like it at all, but that's because it probably made me run to the restroom too much. But you know, like, we think it's different because people are on enteral or parenteral nutrition, but it's really not. Like, you make the same, you have to go through
Yeah.
and figure out what's worth the pain and what's not worth the pain in all parts of our lives. And
Mm-hmm.
so it's no different than dating for the first time and breaking up. It's a heartbreak. Okay, well, my stomach, you know, like, I'm heartbroken now that, you know, I can't eat, well, I can eat, you know, my favorite candy, which is Reese's. I love chocolate and peanut butter. If you're gonna vomit, this is a good tip, guys.
Don't do it. Stop. Okay, go
Make
ahead.
it worth it.
Make it worth it, but also eat something that's good and that tastes good coming back up.
Yeah.
Like peanut butter or chocolate tastes pretty good coming back up. So,
Mm-mm.
you know, like, that's just a tip from somebody who's had to a few more times than I would like to, and not because I overate necessarily, but because it's just all cramped and stayed, and then I'm sneezing or I'm sadly having a bowel movement. It's coming up both ways. We get into the messy stuff where we've all dealt with, where it comes out both sides. But anyway, these are the types of things we need to reevaluate and talk to and be open with our care teams about. And yeah, I think openness is really where we need to just be at.
Yeah, and just remembering that everybody's journey is unique. Everybody's different. Everyone's on the tube for different reasons. I mean, there's tons of reasons why, whether it be, a gastro disease or esophageal or oncology. I mean, I just feel like there's, no matter what the journey is that brought you to enteral feeding, that you're seen, you're heard, you're validated. And that you engage, yes, and engage your providers. Make them do some discovery, on what you need and what's important to you, because this is a big commitment. It's a big commitment, and you're taking risks too. So I think that that's just important that we highlight that.
So thank you for spending some time with us on Tube Feeding Awareness Week, and thank you for joining us and listening. And I hope you found some great tips and tricks along our journey today.
We want to thank you for tuning in with us on Unclamped. We hope today's conversation reminded you that every diagnosis holds a story, one of strength, compassion, and connection. We want to give a heartfelt thank you to our sponsor, AvivoRx, for their commitment to supporting patients and families through their nutrition support journey. Their dedication makes conversations like this possible and provides a platform for the patient voice. We'd also love to hear from you too. If you have a story to share or a topic you'd like us to explore, reach out anytime at nutritiongroup4all@gmail.com. And be sure to find us on YouTube, follow along on our social media, and listen wherever you get your podcasts. Thank you.